everyone. It is my pleasure to introduce our speaker for today's Health for the World International Grand Round, Dr. Susan Palasis. Dr. Palasis is the Director of Pediatric Neuroradiology at Children's Healthcare of Atlanta and Professor of Radiology at Emory University. She is also the past President of American Society of Pediatric Neuroradiology and has made significant contributions in this field. She is a sought after speaker nationally and internationally, and we are fortunate to have her speak at our Health for the Grand Rounds today. The floor is all yours, Dr. Palasis.
Thank you so much. And it is a pleasure and an honor to be presenting to all of you today on a topic that I hope that you'll find interesting and helpful, the pediatric craniocervical junction and cervical spine. So basically, what we're going to do is go over some developmental anatomy. We're going to look at the immaturity of the supportive structures of the spine and how they play an important role in the types of injuries that we see. We're going to discuss abnormal mobility of the craniocervical junction in the spine, and then we'll look at some trauma as well. So the craniocervical junction is a very interesting part of our anatomy. It is both comprised of two vertebrae and two important joints that are both the most stable joints in the body and the most mobile joints in the body. So this is really basic, and I always like to throw in a little bit of Greek stuff because I am of Greek heritage, and the first cervical vertebrae is called the atlas, and that was named after the Titan Atlas, who was punished to carry the weight of the world on his shoulders for eternity, just like the Atlas carries the weight of the head. And the second vertebrae that comprises the craniocervical junction is the axis, or C2. And this is where the atlas rotates around. So this is a very mobile articulation. So two articulations of the craniocervical junction, the atlanto-occipital joint here, very stable, keeping the head attached to the cervical spine. And the second, the atlantoaxial joint, which is comprised of three separate synovial joints that provide extensive motion at the craniocervical junction, both side to side, back and forth, and rotation. So the most mobile joint in the body. So in order to be able to interpret the imaging findings in young children in this area, we have to know a little bit about developmental anatomy. So knowing the embryological development and the age-dependent features of the CCJ and the cervical spine are going to help us understand the pathophysiology of the anomalies that are unique to this anatomic region and the interpretation of the imaging findings that we see. So I'm not going to go into embryology. This is really the only slide that I want to show. It's color-coded here, and it's basically showing the various occipital and cervical somites that form the craniocervical junction. And so the anatomy in this region is really formed by a segmentation and a connection of these somites to form the craniocervical junction. And it's a very complex process that is basically under the control of our genes. So there's two groups of genes that can control the how the craniocervical junction and cervical spine skeletal elements are formed. And those are, one group is the PAX genes, and these are responsible for differentiating the mesenchyme into dermamyotomes, into sclerotomes, and they're responsible for the creation of a long segment of hypo or hyper segmentation anomalies like we can see here. The other group of genes are the Hox genes, and these are responsible or can lead to short segment assimilation anomalies like we see here, the assimilation of C1 to the occipital condyles. And in like the fruit fly, what happens is that these genes will control the segmentation of the insect, like they will determine where the legs are coming from, what part of the insect the wings are coming from. Just like in the human, they will determine what constitutes the craniocervical junction, the cervical vertebrae, thoracic, and so forth. So two important groups of genes. There were two famous physicians back in 1912, Dr. Maurice Klippel and Dr. Andre File, that you can see here, that actually wrote a paper, an important paper that is still very relevant today. And what they did is they described an entity where there were multiple congenital fusion anomalies involving vertebrae. These individuals had a short neck, a low hairline, and had limited motion of the head. And this was the first description of Klippel-Feil syndrome that we recognize today. And Klippel-Feil doesn't have to have the entire spectrum of anomalies that I just discussed, but should have at least two vertebral segments that undergo abnormal fusion. So this is something that you might see. And this just, shows the extent of the abnormalities that we can see in this region under this genetic control. It's important to also understand what is the ossification of the craniocervical junction and the cervical spine, because if you look at a plain film of a young infant, it can look very scary. There's a bunch of lucencies everywhere, and it can be really hard at times to be able to determine, is this normal immaturity or are we dealing with a fracture? So just knowing what the ossification process is approximately is going to be helpful to us. So we'll start with C1, which has three primary ossification centers, the body and the two neurocentral arches that you can see here, and then the two neurocentral synchondroses in blue. And these will fuse at about 7 years of age. So you'll keep seeing this number throughout my presentation. 7 years is an important age to just keep in mind, where at about this age, we should see fusion of these synchondroses, okay? The second one is C2, the second vertebrae. And this is a little bit more complex. We're dealing with 6 ossification centers. The one primary in the body, the 2 neural arches, and then there will be 2 paired ossification centers that will form the dens, and then one at the very tip of the dens. This is the ossiculum terminale. And then again, we're going to have 2 neurocentral synchondroses, and these are going to fuse at about 7 years of age. And then also, when we're talking about the C2 vertebra, we have the subdental synchondrosis right here in yellow, and that also fuses around 7 years of age. Important to remember this number. And then the apicodental synchondrosis right here, this fuses a lot later. It can fuse at about 12 years. Sometimes it doesn't fuse at all. And if you look at lateral, films of the cervical spine, you'll see this little bone that's sitting at the very tip of the dens. That's just the unfused ossiculum terminale. So here's what we might see on the CT of the cervical spine. All these different congenital fusion variants. So, we can have a lot of variety in how the ossification centers fuse. So here's an example of 2 separate ones at 16 months. Here we can see at 5 years. In this 15-year-old, we can see that that left neural arch is not completely fused. Or in this other child, we can see that the anterior aspect of C1 has remained unfused. This is the C2 vertebra here in a 16-month-old with an abnormal unfused ossification center. Should we be worried about these? Well, not too much, because there's strong fibrous unions here, and actually these are not unstable. These do not confer instability to the cervical spine, but they can be points of weakness and could potentially have fractures going through them in the traumatic setting, and we'll talk about this a little bit later. What about the ossification of the remainder of the cervical spine? Well, from C3 down to C7, we're going to have 3 primary ossification centers. Again, the body, the 2 neural arches, and we're going to, you can see here. And then in blue, the neurocentral synchondroses, again, fusion at about 7 years of age. And then you can see how these will progressively fuse, should be completely fused, again, at about 6, 7 years of age. So 7 years is an approximate number, but just an easy number to sort of keep in your head. And then the additional thing that we need to keep in mind for the C3 to C7 vertebrae is that they have 7 secondary ossification centers, and these can remain unfused even into adulthood. So we have the ossification centers of the inferior and the superior and inferior end plate, and the ossification centers that come off the spinous process in the transverse processes. And sometimes these can cause us, you know, a little bit of consternation, especially when we're dealing with a child that has had cervical spine trauma. So this is an example of an unfused ring apophysis, which is a limbus body, and we can recognize it as such. You can see how well corticated it is. So we should be able to, and I'll go through some other additional findings that could point us in the setting of maybe this is traumatic or not. But this is something that we can see as a normal variant. So just keep that in mind. Same thing with the spinous process. This is an unfused apophysis of the spinous process. This is a normal variant. This is not like a clay shoveler's fracture, okay? So, like I said, sometimes it can be challenging to be able to differentiate what represents a just immaturity and, you know, a developmental finding versus a fracture. We're going to look at some things that can point us in the right direction. One is, do we have asymmetric widening of a synchondrosis? Here at C1, you can see the normal synchondrosis on the left, and you can see here the one on the right, how it's asymmetrically widened, it's displaced. And this example here, you can see how the dens is angulated anteriorly, okay? That's not in normal position. The subdental synchondrosis is very wide. And also, we want to look at the soft tissues. Those are going to give us clues as to what we're dealing with. So if you see a lot of soft tissue swelling, like you see here, then you have to be very suspicious that you could be dealing with trauma and not just an unfused synchondrosis. Here's another case of a child with trauma. And what we can see here is that this superior end plate, this ring apophysis, has been totally distracted. Like I said, these can constitute points of weakness, so they can avulse. We can have injuries that can go through them. Also, we have this abnormal widening of the interspinous process here when you compare it to the other levels. And finally, we have soft tissue swelling, and that's going to be another indicator that we're dealing with a trauma in this region. So use these secondary findings. They can be helpful. What about here at C23? We see little ossifications here. Are these avulsed bring apophyses, or are these just developmental variants? Well, in the setting of trauma, I probably would be a little bit suspicious that perhaps these are also traumatic in etiology, as I don't see any at the other levels. So you sort of have to synthesize the whole picture. Okay, what about immature supportive structures, and how do they play into the findings that we may see, normal and abnormal, involving the craniocervical junction? So we know that the immature spine can have shallow articulations. Here is a 15-year-old with a nice deep articulation of the condyle and C1, and you can see in the younger child how much flatter that is. And also the facets in the older children have a more vertical orientation, whereas in young children, they can be more horizontal. And this can actually predispose them to distraction types of injuries, just based on the immaturity of those skeletal elements. Also, we know that young babies have weak necks and can't really hold their big head very effectively. And so stability in these young infants is primarily conferred by the soft tissues and the ligaments rather than bony. And this can also lead to soft tissue injuries of the cervical spine. They can be serious. We're not going to see fractures to the same extent in these young infants as we do in the older, more skeletally mature children. So here's another example of how we need to be aware of this normal ligamentous and soft tissue laxity that we'll see in young kids. So if we look at the atlantodental interval right here on the sagittal CT, we can have an atlantodental interval that can be up to 5 millimeters wide in children under 9 years of age. And we know in older children and in adults, we want to keep this interval at about 3 millimeters. But young children, they're allowed to have it wider and not be concerned about an injury because of this ligamentous laxity that they have. Also, the ligamentous laxity can lead to widening of the interspinous distance, especially at C1 and C2. And sometimes it can be challenging to try to determine whether this is a normal finding in a young child, or are we dealing potentially with a distraction in this area? Again, we're going to look for soft tissue findings of swelling and whatnot, and we can compare to the interval below and make sure that it's not above 1.5 times the distance of the interval below, if you want to keep sort of that as a number in your heads. Ligamentous laxity can, lead us to be concerned about prevertebral soft tissue swelling on a lateral view of the neck, where you could be like, oh, is there an injury in this subdental synchondrosis? Are we dealing with soft tissue swelling? Do we need to be concerned? But if you repeat the plain film with better technique and inspiration, that fullness of the soft tissues can actually go away and give you some confidence that things are okay and you're just dealing with immaturity here. Okay, abnormal movement in the craniocervical junction is important. And we can have different types of abnormal movement, hypermobility, instability, and fixation. So when we're talking about hypermobility, we're talking about maturational changes that can occur. Like I showed you, a young child can have a lot of mobility because of the ligamentous laxity of the soft tissues. Children with Down syndrome, hereditary connective tissue disorders, odontoid anomalies, all these conditions can have hypermobility. And children with hypermobility, that just means that in the normal plane of motion of the cervical spine, they have a little bit too much motion, but these are not painful conditions. Versus instability is where we have abnormal motion at the craniocervical junction. And that's usually going to be secondary to disruption of supportive structures. That could be traumatic in etiology or could be inflammatory in etiology. And then finally, we can have an abnormal fixation of the craniocervical junction, and I'll review that as well. So it's important to understand the joints of the craniocervical junction, and because they're the ones that will confer the stability to this region. So the stability of the atlanto-occipital joint is primarily going to be due to the capsular ligaments that we can see here. Very, very strong and keep the occipital condyles fixed to C1. Now, atlantoaxial joint's going to be a little bit more complicated. In the stability to this joint is going to be conferred by multiple ligaments. The apical ligament in gray, the alar ligaments here in pink, the cruciate ligament, which is a key ligament here, very important, probably the most important ligament, along with the alar ligaments in regard to stability at the atlantoaxial joint. And there's a transverse ligament that we can see here that's part of that cruciate ligament. And then the tectorial membrane, which sits over these ligaments, also leads to the stability of the atlantoaxial joint. So what happens when we have a traumatic instability? Well, let's talk about first about atlanto-occipital distraction. This is a more common injury in children than adults. Again, because so much of their stability is ligamentous and soft tissue in nature, and they have this immature anatomy that renders them susceptible to these types of distraction injuries. So what we want to look at, then these can be very, very hard to detect. And in full disclosure, I will tell you that even as an attending neuroradiologist, I have missed these injuries because I haven't paid close enough attention to the subtle findings. So, you know, in a traumatic setting, you really need to pay attention and scrutinize the relationships of these joints. Here you can see that there's an abnormal widening and an offset of that atlanto-occipital joint. And then on the coronal view, you can see that there is some widening as well, more so on the right. It's more, you know, visible on the right than on the left. And we have a measurement of about 5 millimeters. We don't want to go over 5 millimeters because then we're going to be concerned that we're in the abnormal range. This is a bigger number than what we see in adults. Adults, we really want it down at that 3 millimeter level, but children, we can allow them to be a little bit wider, but we want them to be symmetric. If we have any concern, really the examination that we need to go to is MRI. And MRI really plays a very important role in evaluation of craniocervical junction and cervical spine trauma in children. These injuries can be really hard to detect just on CT, and MRI is going to be very helpful. And here we can see the asymmetry of the joints in the fluid that's accumulated within these joints. Atlantoaxial distraction, again, more common injury in children than in adults. Again, we're going to look for asymmetry. Look at how the atlanto-occipital joint here is in better opposition and how wide that atlantoaxial joint is, above 5 millimeters. This is concerning. And the MRI clearly shows that we have fluid, both in that atlantoaxial joint that, or atlanto-occipital joint that did not look particularly wide, but significant findings in that atlantoaxial joint. Atlanto-occipital and atlantoaxial injury can occur together. And when they do occur, those children are very high risk for spinal cord injury that we can see here. So we can see all this edema in those nuchal tissues, in the prevertebral soft tissues. We can see the cord here with this significant injury. Additionally, you want to look very closely for vascular injury at this level, because the vertebral artery, as it's coming through the foramen transversarium, it comes out at the level of C1, C2 to enter the intracranial compartment. And this is where it can be very vulnerable to injury. And I'll tell you that these vertebral injuries can be really hard to see, and you have to look for them deliberately on MRI. Sometimes you have to go to CT. Again, very hard to see on CT because they blend in. The contrast enhanced vessel is going to blend in with the bone. And these 3D reformations are really helpful in showing injury. In this case, we can see that there's a dissecting aneurysm of that vertebral artery at that level. This is an example of what we might see in a traumatic instability in a 2-year-old in a motor vehicle accident. Again, the subdental synchondrosis is a point of weakness in a young child. And fractures can occur through this region. They can be hard to detect on a plain film or a CT unless you have this displacement and angulation. But look at all the findings that you see on the MRI: extensive edema, clear distraction, cord injury. So MRI, much more revealing. In a mature skeleton, like in this older child, we can also have fractures that go through the dens. We can look for, they're going to be very obvious, of course, on a CT versus, in the immature child, that we could, have a differential dilemma of whether we're dealing just with an unfused synchondrosis or a fracture. Here it's pretty clear we have a fracture. But again, you can see how the MRI is useful in showing us the extent of the soft tissue injury, the rupture of the ligaments, and the injury of the cervical cord. There are 3 types of fractures that can involve the odontoid. This is in the mature skeleton. We can have a avulsion of the tip, a type 1. This is a stable injury. The type 2, which is also the most common type, extends through the base of the dens, and this is unstable. So if you see this, you need to be talking to neurosurgery. And then the other one is the type 3, which is like the type 1, but it extends further down into the body of C2. And these are also unstable, but they have a better prognosis than the type 1s because they can heal more readily, whereas these are more prone to non-union. Now let's talk about hypermobility. So abnormal motion at the level of the craniocervical junction. This is a child with Down syndrome, and we know that they can have this laxity of ligaments. And here you can see how wide that atlantodental interspace is, much wider than our threshold of 5 millimeters. That whole C1 is moved anteriorly. And then this is the MRI in neutral position. You can see how that C1 has actually moved back, right? And we still have some fluid in that joint. But look at the cervical cord here and how it is thinned. And it's interesting that these children are pretty asymptomatic. They don't even have neurologic findings until much later. And that's because the injury of the cord is repetitive. And it's not severe, but it's a repetitive injury. So the cord actually adapts. And these children don't present with acute symptoms versus if there is an acute trauma and we had a traumatic subluxation and an impingement of the cord, then that child would have serious neurologic symptoms. Odontoid anomalies can lead to hypermobility, and the one that we see in this region is the os odontoideum. And that's where we have non-fusion of the os with the body, with the remainder of the dens of C2. And the os adentoideum sort of has a controversial etiology. Some people are saying it's just developmental. Some people are saying that, oh, maybe it's a result of a remote injury that occurred maybe in the perinatal period. Regardless, it will lead to hypermobility of the craniocervical junction. And there's two types of os that we can see. The one is the orthotopic, where it's in a normal relationship with C1, the anterior arch of C1. And the dystopic os is when it's fused with the tip of the clivus and in an abnormal position. So just so you know, those are the two different types of classification. And what can we see within os adentoideum? We can see abnormal motion of C1, C2. You can see how in flexion it's slipped anteriorly and how in extension it goes back to a normal position. So if we're suspicious of an os, sometimes they can be hard to detect on a plain film because of all the overlapping shadows. Recommend flexion and extension views, and it should become apparent. And the neurosurgeon will typically go in when we have this degree of excursion, they'll go in and they'll fuse these vertebrae. What about the unfused ossiculum terminale? Is this an unstable injury or an injury that leads to hypermobility? Should we be concerned? The answer is no. This projects above the level of the alar ligaments, and it does not confer any instability to the craniocervical junction. So it's just an incidental finding that we need to recognize. I'm just going to say a little bit about rotatory fixation. These children will come with their head in a cock robin position. This is a cock robin, and this is how they hold their heads. So basically, they'll come in with a torticollis. And these these are acquired abnormalities. Sometimes they can be associated with inflammatory disorders, inflammation that can occur in the retropharyngeal soft tissues. And if you treat the underlying inflammation, then that fixation, that torticollis can resolve. Or they could be traumatic in etiology, and this can be a fixated anomaly. So what do we see? On the open mouth odontoid view, we'll see this asymmetry of the dens relative to the lateral masses of C1. Now, if we have a child less than 4 years old, we probably should not be wasting time trying to get an open mouth odontoid view. The bones are, not well ossified. We're going to see a lot of lucencies just because of immaturity. And they tend to not, these young children tend to not be cooperative. So not a very helpful view in these young infants. We can do CT in the neutral position. As you can see here, this is a nice example that I probed from this paper. And you can see how in neutral position you have the abnormal rotation of C1 pointing in this direction, C2 pointing in that direction, and that abnormal relationship remains the same with the rotation of the head. So this is what a rotatory fixation might look like. It's important to look at the sagittal views of the cervical spine and look at the distance of the atlanto-dental interspace, because that's going to tell us whether these patients are going to be surgical candidates or not. I find that the 3D reformatted images of the craniocervical junction are really helpful because it's, I don't know, I have a hard time, with this diagnosis, just looking at it in the axial plane. But if you can do a 3D reformat, you can see how very nicely aligned these facets are on the right side and how misaligned they are on the left side. So it becomes very clear that you're dealing with this rotatory subluxation or fixation. And we can classify this using the Fielding and Hawkins classification scheme. There's the 4 types, type 1 to 4. And basically, these are divided into these 4 types based on what the anterior positioning is of C1 relative to C2. That's why it's important to look at that atlantodental interspace. So if it's less than 3, we're dealing with the type 1. If it's 3 to 5, it's widened, then we're dealing with a type 2. And these types 1s and type 2s, we'll just do pain management, immobilization, and muscle relaxants and hope that they will come back into normal position. But if we see greater than 5 millimeters displacement, or if we see posterior displacement of C1 on C2, well, those are going to require surgical intervention just straight up from the beginning. Now we're going to talk just a little bit about pediatric cervical spine trauma. So important to know that the fulcrum for injury in younger children is in the upper cervical spine, and for older children in the lower cervical spine. And this makes sense, right? Because young children, young infants, they have big heads, weak spine. With the forward motion of their head, it puts a strain on that upper cervical spine. Whereas in older children, where they're completely ossified, the range of motion tends to be more pronounced in the lower cervical spine. So here's an example of a 22-month-old with a history of motor vehicle accident and actually went undiagnosed for a cervical spine injury. They did initial plain films. They did not look worrisome, and they stopped there. Well, the child then had neurological symptoms. They did the CT. They saw the clear displacement of the dens, the fracture through that subdental synchondrosis, and they got the MRI, and the traumatic findings are very obvious here. You can see all this edema, you can see the displacement, and you can see the cord injury. Versus this 14-year-old cheerleader who had neck pain following a fall when she was doing one of her cheers. And the injury here is in the lower cervical spine. We can see the narrowing of the intervertebral disc space, and we can see little bone fragments actually displaced posteriorly into that cervical spinal canal. The MRI, again, is going to show us the full extent of the injury. We can see the abnormal angulation here, the abnormal disc with the extruded disc material, and touching that anterior cord. Again, fulcrum of injury in the lower cervical spine in the skeletally mature child. There's an entity that's called SIWORA that stands for spinal cord injury without radiographic abnormality. And this is when, before the days of CT, or before the days of MR actually and CT, where we're just doing plain films, these children would have these severe neurologic symptoms, yet their plain films and their CT would be totally normal. They had signs of myelopathy. So here's such a child, a 20-month-old, that had a temper tantrum and hit the back of the wall with their head and presented to the ED with acute quadriparesis. Normal MRI, very abnormal. You can see all this cord signal abnormality secondary to cord contusion and then subsequent ischemic injury as well. Due to this stretching of the cord, they can occur. Again, remember the ligaments are very lax and they have a greater excursion than the cord itself. So if you have extreme stretching of those soft tissues, you can actually cause a stretch injury of the cervical cord. When do we image the cervical spine? Because we don't want to radiate these children unless we have to, right? Well, there's a group of criteria that we can follow that can guide what our imaging evaluation is. The nexus criteria and the PCARN findings. So based on what we see, do we have midline cervical tenderness, focal neurologic deficits? Is the patient non-alert? Are they intoxicated? Are we suspicious of distracting injury? is a high risk mechanism for injury. These are the cases that we're going to want to do imaging on. So basically, how are we going to image the pediatric spine in the trauma setting? Well, we like to start with plain films. They're easy, and we can start with just AP lateral of the cervical spine. Remember what I said about that odontoid view. We really just want to not even try it in children less than 4 years old. They're not going to cooperate. CT. If we're in a polytrauma setting, or if the child is unconscious, then we need to scan the entire cervical spine, because we can't speak with the child to see where's the pain, where's the problem. Otherwise, if they can localize where the area of pain is, or if we do a plain film when we see a focal abnormality, we're concerned about a specific cervical spine fracture, we can do a targeted CT just through that level, and we can spare that child all that radiation. It's hard to get this done. I know that many times our ED doctors, they just want to scan the entire cervical spine, but as radiologists, we need to always try to advocate and try to use the criteria of ALARA, which is to use the lowest radiation dose possible in our diagnostic imaging studies. And of course, MRI is going to be very important to reveal injury that may not be apparent with plain films or CT, especially in young children, as you just saw. But if there are any concerning neurologic findings at all, or if we're concerned about possible abusive head trauma, then we absolutely need to do an MRI of the cervical spine. So I'm going to just go a few more minutes. I don't have that many more slides, and talk a little bit about abusive head trauma, because the spine plays an important role, the spine and the craniocervical junction. So when we're dealing with abusive head trauma, plain films and CT are not going to be sufficient in excluding injury. So if we're suspicious, we want to recommend that MRI of the cervical spine be performed with an MRI of the brain. So all of our abusive trauma MRIs should have both brain and cervical spine injury, because the mechanism of the abusive head trauma may be readily apparent on the MRI of the cervical spine. Now, if we see an injury like this, we have this nuchal edema, we have this stretching, this ligamentous injury. The cord looks great, the spine looks great. We don't have any marrow edema, no cord edema. This child may not have any significant findings. Do we just say, oh, well, it doesn't really matter what we see in the cord? It does, because even though this may not hold clinical relevance, it can hold medical legal relevance. So when we're in the courtroom and trying to make the case that we could be dealing with abusive head trauma, we want to show that we've had this whiplash mechanism of injury that's involved the soft tissues of the proximal cervical spine. So if we see findings in the brain of a hypoxic ischemic injury in a case where we're suspecting abusive head trauma, we're not seeing any blood, we're just seeing hypoxic ischemic injury, well, we need to look at the cervical spine, because that stretching of the cord and the medulla that can occur with this whiplash mechanism of injury that occurs with abusive head trauma can lead to apnea, that can lead to anoxic brain injury. So just to end, some key takeaway points. Remember the developmental variants that we just reviewed. Remember the 5 millimeter number for the atlantodental interval and for that atlanto-occipital and atlantoaxial joint. And remember just a gross time frame of 7 years, where we really want to see the majority of the synchondroses fused. Maturity is going to determine what types of craniocervical junction and cervical spine injuries that develop. More proximal injuries in the immature spine, more distal cervical spine injuries in the mature spine. And remember that MRI is an important modality for evaluation of the pediatric craniocervical junction and the cervical spine in young children. So I want to thank everybody for your attention. And if anybody has any questions, I'll be very happy to take those.
Thank you so much, Dr. Palasis. That was an excellent talk and some very nice images. And I'm sure, I'm very positive that all our attendees had a lot to learn from. I see one question in the Q&A box. What is the reason to do lateral neck X-rays in end inspiration?
In inspiration?
In end inspiration, yes.
Yeah. Oh, well, the significance is not as significant in the older children, but in the younger infants. Remember, we have all that laxity of the soft tissues. So remember, I said that we need to look at other ancillary findings that could indicate trauma in the cervical spine. So because we have all these unfused, apophyses that could look like fractures, so we want to look for soft tissue swelling. Well, if you have a young infant and you see full soft tissues, could that be soft tissue swelling? It could, but could also just be ligamentous laxity. So a good way to, clear things up for yourself is try to repeat it in a good inspiration to try to flatten those, to distend the hypopharynx and flatten those lax soft tissues out. And, it will just give you more confidence towards making an accurate and correct diagnosis.
And a follow-up question to that was indications for flexion and extension views. It's by Nitesh Agarwal.
Yeah, so we recommend flexion and extension views whenever we have suspicion of instability, which means if I see a wide atlantodental interval wider than 5 millimeters, perhaps I'm dealing with an instability. And the only way to really demonstrate that is to do flexion and extension. Our neurosurgeons here, they like to do MRI in these children with C1, C2 instability because they want to see is there any compromise, impingement of the cord with these maneuvers. And we will always make sure that we get plain films in flexion and extension first so we can see the degree of severity of that instability, because the last thing you want to do is put a child in the scanner, have their head in flexed position for 5 minutes while you're getting your images, and then you see that you're actually impinging the cord. So we'll always request flexion extension views before we do any dynamic maneuvers in our MRI scanners.
That's an excellent point, thank you. We also have a question from Dr. Sandeep Nayak, who's asking, what is the significance of tectorial membrane elevation? Does it indicate substantive craniocervical junction injury if it is adjacent large ligamentous edema?
Okay, you're breaking up a little bit, so I wasn't able to hear it very clearly. What was can you repeat that?
So the first part of the question was, what is the significance of tectorial membrane elevation?
Oh, tectorial membrane elevation. Yes, yeah. Very significant. Yes, thank you. And that is a very easily missed finding. So we have to look at it because it may not mean there's instability, but it means that there's injury. And then we have to be, I would, in that instance, go to an MRI to be able to evaluate any additional areas of ligamentous injury, abnormal signal in the ligaments. I'm hesitant to say do flexion and extension maneuvers because we don't know. It's a trauma. We don't, I don't know how unstable the craniocervical junction could be. And the other thing is, in the acute setting, those children have a lot of pain and they're not going to cooperate to flex and extend their necks anyways. So if I see that distraction injury, I'm concerned for ligamentous injury, and I would recommend an MRI and further evaluation.
That's an excellent point. A follow-up question was that does it indicate, injury as you mentioned, especially if there is adjacent alar ligamentous edema? So is it something that we look for?
So I didn't hear, wasn't very clear again at the end. Does it indicate injury? Yes.
If it is the alar ligamentous edema, like if we see alar
If it's
ligamentous.
ligamentous edema, yeah, absolutely. That would indicate injury. And as I said, MRI, don't rely on normal plain film and normal CT in these young children. They can look normal, and MRI really is the way to assess the entire extent of ligamentous injury or injury to the cervical spine in general.
Thank you. We have one guest who's raised his hand, so I'll just allow Dr. Bacon to speak if he wants to ask a question.
No?
Maybe it's by mistake. I can ask a question by the time we are waiting to hear from others. I was curious to know, as a person who's a trainee or who's just starting out, what are some tips and tricks you would recommend, especially as they, get into this field of neuroimaging? What are some things to look for and not to miss, and how we cannot miss subtle findings, especially the case that you showed of atlantoaxial distraction. Like, since it is so subtle, it's easy to miss. So what are some tips and tricks you would recommend?
Just for cervical spine or just pediatric neuroimaging in general?
Both.
This is the key to pediatric neuroimaging, is really to understand development. If we don't understand normal development of the brain, of the spine, of the supportive structures, we're not going to be able to differentiate normal from abnormal. And this is really the challenge of pediatric neuroimaging and why it's so fascinating and such an interesting field. So we have a lot more to learn. We need to know all the different stages of normal. So my recommendation is remember sort of what you expect to see in a young child, in a 3-year-old. Don't let all the lucencies that you're going to see throw you off and make you nervous, like, oh, is this a fracture? Understand that those can be normal findings. And we really have to synthesize the history that we get, which is so important. We have to have the history. Was there trauma correlated with the finding? How old is the child? Another very important piece of information for us to be able to differentiate, with this, whether this is a normal finding of immaturity or this is a true abnormality. Other ancillary findings, edema, even like in a head injury, if you look at where the swelling is, it's going to direct you to see to where the fracture is or where the injury of the underlying brain is. So we just have to sort of be like detectives and see all the subtle findings and put them all together, synthesize the entire picture.
Those are very important words of wisdom, Dr. Palasis. We often miss that in the big clinical picture, but that is so important. And I see our guests are also mentioning that it's an amazing session and they really enjoyed the talk. And it was such an honor to have you as a speaker in this grand rounds. I personally learned a lot, and I'm sure all the other attendees also learned a lot. It was great having you, and thank you to all the attendees for joining from all over the world. And I believe this recording can help, others who are seeing this recording on the weekend. So thank you so much, everyone. And thank you so much, Dr. Palasis.
Thank you so much for the invitation. It's been a pleasure, and have a good day or night, everybody.
Thank you, Dr. Palasis.
Bye-bye.
Bye-bye, everyone.